Thank you very much, Professor Comey. Thank you, organizers, for inviting me. These are my conflicts of interest. They really don't relate to this. Introduction and idea. It is that EM lesions are associated with brain tissue responses, but also behavioral responses. We know that in tissue, after a focal injury, they immediately think of a stroke. There is a tendency to repair plasticity. As we know, there's a larger spinal formation around the lesion. And things are more complicated in the M because not all lesions are detected and not all of them have symptoms, because some only affect the myelin, as Professor Harton said. So we need to detect demyelination early. One of these methods may be evoked potentials, as Professor Horton said, and the one that explores motor pathways is TMS, which is transmagnetic stimulation, and the lower strokes are from peripheral stimulation, and the upper strokes are from cochlear stimulation recorded in the hand muscles. And on the right, you can see the response to cochlear regulation is much smaller and delayed. This can happen without symptoms. Most of the time, symptoms do not appear when there is only one delay without a reduction in amplitude, but even with delays, we can predict that there will be disabilities in about 2 years. We can predict it in 80% with 80% accuracy. So in order to fall into the window of opportunity, we can also apply these tests regularly to detect spinal cortical lesions and try to react. Reaction before axonal loss occurs, and one reaction may be rehabilitation. And I'm talking about preconditioning because we can promote brain plasticity before axonal loss when we're in remelting or even before. Rehabilitation results in brain plasticity, which can be well measured by atrophy measurements such as Professor Ontaneda showed us today that we know that exercise can also have a neuroprotective effect, so it may have a specific effect on the brain. But speaking of the window of opportunity, we may also waste time in clinical studies dealing with the effects of exercise because most studies are meta-analyses of the URIC group. He is a great promoter of exercise as a disease-modifying treatment, and he has seen most studies begin in people 5 years after their illness. Maybe we missed part of that window of opportunity by not starting to eject. Exercise early and promote better action preservation. And in other disciplines, they do it. They exercise early. Before the engine deficit occurs at NASA, before sending astronauts into space, they train them for a couple of years to build muscle in these places where they know there's going to be a loss to prevent partner abnormalities, but they do it 2 years before the damage occurs. So we also have the concept of preoperative surgery, which is now widely used before major surgery, orthopedic abdominal cancer, and in 2018 I started doing PubMed to try to find out about Amy. I didn't find anything in many articles. They're accumulating in surgeries. Maybe it's time for us to do something about it, because we know that people should not wait for their locomotives to be affected, even under EDSC. 4. When we see the limitations of walking, we can see that if we do motor tests, the resistance, it has been greatly reduced beyond EDSS 1.5, although it is still below 3. So this is also reflected in more severe fatigue and balance damage. I think it's too late to wait for the disability to become apparent, which is why we have a pre-qualification for the title. But how can we attack small deficits before they are clinical? We will already do cuticle measurements, such as evoked potentials, but we can also use sensors that are used in the body, which can measure gait and are very useful for quantifying various aspects of gait and simple tasks. Dual tasks are also affected in people with MS. And also to measure the effect of rehabilitation, to demonstrate an improvement. On the left, you can see the difference between healthy people and the right, and you can see the effect of rehabilitation. But there is also the possibility of defining the quality of the accordion. In different situations, when you take off your shoes and walk in socks, your gait is much worse. Of course, they are people with progressive MS, but the change is quite significant. There's a big deterioration compared to healthy people who don't care so much. And this makes me think that maybe that we don't have enough gait tests to see what happens to people in real life with the right shoes we wear in the lab. Maybe we should follow up on it at home in your daily activities, because it's not just the kind of equipment that people have in the lab. It's much more sophisticated, including the shoes that patients wear. But also boarding. The patient's attitude is different in the laboratory that is his attitude at home, for example. We already know the doctor is watching us. We're doing our best. And this is written as the Hawthorne effect, which was described by a social scientist when he was a factory to measure the effect of lighting on workers' production. And they found that when they went there and the light increased, they did better, but when they went there and turned the light down a little bit, they did better. And they just got better because they saw them measuring and trying to do their best. This can happen to healthy people, even when walking speed is measured, and if they use wearable sensors, it can also happen to people with EM. Even healthy people walk much faster when they're in the lab than when they're home. So the drop in speed that they can see is what happens when people are home. In addition, people with EM tend to walk less and spend more time in bed, as you can see below left with EM. This is more evident with, although the EDSS is less than 5, you can see that the increase in EDSS is more resting or sitting longer. So we have to do something to promote physical activity, of course, in the early stages of the disease.
The number of these points in 2 years, and then we have to observe these definitions because of the number of these points, we have to understand them. But I have to say that even measuring this number includes various factors, which is very important because even although this does not prevent these factors from worsening in the future, it is very important for people who have received this software to be able to monitor these studies and this point that there is a decline. We see that patients have to start with this on the left hand, and they have to see it worsen later because this does not happen in patients who do not undergo lockdown. Even the number of patients may be at higher risk of regeneration. Then we have to reduce the measures and use other, more sophisticated measures. For example, the speed of different points is very important, and it is also necessary to provide sensors to measure qualitative points. Then not only. So we used a lot of sensors to perform these tests, and they had to be more sophisticated because they provided measures of walking quality and understood that more than 600 people with multiple sclerosis had this type of pain. We saw, how can I tell you if we can improve this progression reduction by using more measures? But we have taken many measures to find that these initial damage points may have these potentials or reduce walking ability, and we have many tools to counteract them. Inactivity or promoting physical activity, and we had indications. We can use the technology that was promoted during COVID for people who are having this type of problem, but we can also use it for people who don't have this yet. One example is that people don't. Can you have this? Did they also use this rehabilitation point as in the results? We've already had meta-analysis to see balance, neurological inactivity, and it could be important. So we're closing this point, and remotely we can use these important points. This is a way to start early in people who are not disabled. And well, an example that has already been proven by me. He said they also use these commercial rehabilitation devices to provide them to people who are not yet incapacitated to carry out such training with good results or walking measures, but also after. We can improve other symptoms, and we have made a point in Germany about fatigue with these therapies. And recently, last year, we were able to see the positive results of these intervention points with this level of treatment for people with regression. Multiple sclerosis compared to. But if we don't want to use technology, then we can see that there is an important point in improving the specificity of people with multiple sclerosis, balance, walking, and exercise. This is something we really want to use. It's the guy, for example, the shoe guy. And other tools, so it's worth treating us, and another possibility to train and strengthen these points for the devices we want to perform. So, also talk about exercise and these projects, and compare the fact that we have this rehabilitation alone. We have this COVID-related rehabilitation exercise. Unfortunately, the study was negative and there was no difference between the 4 groups. But this is even because the control shows us that it is improving the physical function and cognitive field. We also see that this is a controlled form, a controlled condition. For example, doing these research related to these points. So another way to improve this is what we need to be able to promote spectacle in order to increase brain space. We know that we use them in the motor cortex to see the results and representation of the motor cortex approach. We can also improve these representations by not only inhibiting them but also reducing the hemisphere involved in focal lesions. This could be that we promote even if we combine this. This brain information has been used, for example, in cognitive rehabilitation, fatigue, and it has been shown that in addition to using this, we have a good point in using this rehabilitation. We have successful data from our colleagues at Chappie in New York who combine this with cognitive rehabilitation at our institute. We have a very successful point, and combined with this kind of rehabilitation that is improving. In the countryside, even after this discharge, the dotted line after the patient was discharged shows us that all of this exists, while the other patients had these physical activities with this neuromagnetic stimulation after 15 weeks. So after 13 weeks of high, they returned to their original state. It's a way to improve the duration of recovery. Even patients with axoma can use OCT less likely, but I think in the future we can choose patients to have this kind of virtual neuromodulation, virtual reality, or robotics. So we can stop waiting for the patient to have rehab. How can we choose? Well, it's with the same list of tools that the doctor has already shown us a way to measure this OCT. Action points, all of which I would like to thank you very much for your attention.